Dr. Nina Logan, Senior Director for Research and Clinical Programs for Blood Cancer United, and welcome to the Southern Blood Cancer Conference, CAR T-Cell Therapy, Mechanism, Toxicities, and Future Directions session. We're excited to have you join us here today in person. As you might have noticed, the Leukemia and Lymphoma Society is now Blood Cancer United. We have evolved how we look to ensure every blood cancer patient and caregiver knows that we provide support for 100 plus blood cancers, not just leukemia and lymphoma. While our name has changed, our mission remains the same. Now I have the honor of introducing Dr. Hong Dae-Sa. Dr. Dae-Sa is board certified in internal medicine and pediatrics with fellowship training in hematology oncology. She is a Northside Hospital blood and marrow transplant, leukemia, and immunotherapy program physician. Her clinical research interests include blood and marrow transplantation, CAR T-cell therapy, TIL therapy, and acute leukemia and hematologic malignancy therapies. So, Dr. Dae-Sa, we will let you take it from here.
It's really great to see all of you here this morning. I'm Dr. Hong Dae-Sa, and I am at the Northside Blood and Marrow Transplant Program in Atlanta. So today I'm going to cover quite a few topics regarding CAR T-cell therapy, mainly focusing on the mechanism of action. So what is it? How does it work? And then I'll talk about some of the potential toxicities. And then lastly, I'll end up going into what the future of CAR T-cell therapy looks like. So here's an outline. Briefly, we'll start with understanding what the immune system does in terms of cancer control, and then that'll lead into understanding how CAR T-cell therapy works by harnessing the power of the immune system. I'll go over the timeline of events for what patients and caregivers might expect if they're going to receive this therapy, and then talk about some of the FDA-approved indications and the efficacy behind them. Then I'll talk about toxicities and management. So what are the side effects of CAR T and how can we help to prevent them and then treat them if they happen? And always there are logistical considerations for patients, family, and caregivers before undergoing any cellular therapy. And I just want to make you aware of what some of those considerations might be. And then I'll round out by talking about the future of CAR T. All right. So, immune surveillance against cancer is a really important concept that I want to help you understand before we get into how CAR T works. So in the early 20th century, there was a Nobel Prize-winning scientist named Paul Ehrlich, and he studied hematology and immunology. And at that time, he hypothesized that a person's immune system can recognize, attack, and eliminate cancer cells. And this theory, or this concept, later developed into what was called the tumor surveillance theory in the 1950s. So what you can see in this graphic, very simplified, is that on the left, the cancer cells, which are in light blue, interact with a patient's immune cells, or a person's immune cells, and through the process of immune surveillance, the immune system can eliminate cancer cells. So fast forward to now, sorry, I'm a little short. Fast forward to now, we can understand that two types of immune cells, natural killer cells and T cells, are key players in seeking and destroying not only cancer cells, but cells before they become a cancer. And so what you can appreciate then is that healthy immune systems are very good at stopping some cancers from taking hold, but cancer cells can be very smart and they can find ways to outsmart the immune system, to mutate or to overcome the immune surveillance. And when this happens, there's a phenomenon called immune escape, which is when cancer can develop and spread. So immunotherapy is a broad term that's used to describe a lot of different treatments that are based on this concept of the immune system being able to recognize and kill cancer cells. So cancer cells in a person's body, among other things that shouldn't be there, like bacteria, viruses, fungi, they all express proteins on their cell surfaces called antigens. And these antigens basically signal to the immune system that, hey, I shouldn't be here, I should be removed. And T cells, which are one type of immune cell, are able to recognize these foreign antigens and then destroy the cells that express them. They can do that through direct killing of the cell or through a very powerful process of getting other immune cells through activating other parts of the immune system to help with that killing. And so this is a very effective response because the immune system can propagate its effect. So what you can see here is the antigens on the surface of the cancer cell, and the T cell can recognize them. So with immunotherapy, we're able to harness the innate power of a person's immune system to destroy the cancer cells. And this is in contrast to what we consider conventional chemotherapy, which it can directly kill both healthy and cancer cells, and the effects aren't as long-lasting as immunotherapy. Okay, so now that you understand the concept of immunotherapy and know why it works and why it can be so effective, I'm going to talk specifically about how CAR T-cell therapy works. So what are CAR T cells? Basically, they're called CAR T because they stand for chimeric antigen receptor T cell, which is a mouthful. And I'll walk you through what chimeric antigen receptors are. So T cells are collected from a patient and sent to a lab. And in that lab, they are genetically modified by insertion of a gene to express a receptor that can specifically recognize cancer cells. So you can imagine that this is the gene insertion, and then once it's inserted, the CAR T cell is created. So the T cell now has a new receptor that can recognize a specific antigen. In this graphic, I have CD19 as the antigen, which I'll talk about for some of the FDA-approved products. And the receptor on the T cell can now recognize CD19 on the cancer cell. Okay, so once the cells are engineered to express this CAR, they are grown or amplified in the lab and then sent back and reinfused into the patient. And I'll talk about those steps in a little more detail. Once the CAR T cells are reinfused into the patient, they can then go to the cancer cells that express that antigen and then kill them. Chimeric antigen receptors, just for full understanding, very briefly, they have several different features that make them so effective in prolonged targeting of cancer cells. First, they have on their cell surface an antigen recognition domain, and that's the part of the receptor outside the cell that actually attaches on and recognizes the tumor cell. And then they have a domain inside the cell called the intracellular domain, and that functions to activate the T cell, as well as to activate other T cells and other immune cells that then recruit more immune system activity. And once in the patient, this is considered a quote-unquote living drug, because the T cells can self-propagate, and then that leads to the ability to control cancer over long periods of time, and sometimes can even lead to a cure. All right. So now I'll talk about the timeline of events for someone who is considering undergoing CAR T cell therapy. Okay, every patient who is being considered for CAR T will have a comprehensive evaluation. So this will be the initial consultation, and this includes meeting with a cellular therapy doctor. And at that visit, a detailed review of the patient's history and other medical conditions will happen. We'll also check labs looking at infections, organ function, and we'll do a pretty thorough assessment of what your hearts, lungs are able to do, physical fitness, and always we want to consider psychosocial support and caregiver support throughout this process. Once the patient and their cellular therapy team then decide that CAR T is the next best step, then the process starts to get the patient to the therapy. Okay. Here you can see a schematic taken from the National Cancer Institute, or the NCI, of the different steps in the process, and I'm going to walk you through each one. The first step is called collection, And this is the process of taking T cells from the patient, and we do this through a process called apheresis, or specifically leukapheresis, which takes out the white blood cells, the T cells. And this procedure is similar to if you were donating platelets. So if you know someone who's donated platelets or you've done it yourself, we will place a temporary central line, and it has 2 lumens. One of the lines will go through a machine to filter your blood, and that filtering process removes the T cells, and the rest of the blood is then returned back to you. This procedure generally takes a couple of hours, so we estimate about 2 to 4 hours that you'll be hooked up to that machine. It's very safe, there are very minimal side effects. Once the T cells are removed, then they are shipped off to a lab where the production of the CAR T cells happen. And the T cells, as I mentioned, are genetically engineered in the lab to express that CAR. Once the CAR is expressed on the T cells, then they're grown or expanded until they reach an adequate number. And once that number is reached, they're frozen, shipped back to the hospital where the patient is being treated. And this process generally takes about 4 weeks. We always estimate between 4 to 6 weeks. So it can be quite some time that the cells need to be manufactured. And during this time, the patient, after the T cells are collected, is at home. They may or may not be receiving additional therapy for the disease. And so if patients receive a therapy between the time of the cell collection and the cell infusion, we call that bridging therapy. And the purpose of bridging therapy is sometimes to get the disease under better control before going to receive the cells, or to achieve a deeper remission. And then the third step in this process, when the cells are shipped back to the hospital, is reinfusion into the patient. And there are 2 steps in this process, I would say. The first step is low-dose chemotherapy, or lymphodepleting chemotherapy. And the purpose of lymphodepleting chemotherapy in those days leading up to the cell infusion is to prepare the patient's body to receive the cells. So we like to make room in the patient's body by taking or eliminating some of the immune cells, so that when the CAR T cells are infused, there's space for them to grow and to do their job. So the cells are shipped back from the manufacturer to the hospital. They're thawed because they were frozen, and then once they're thawed, they're reinfused into the patient. And this is a very simple process. It kind of looks like if you were receiving a blood transfusion. The cells are in a bag and it's infused into an IV. We usually do this in the hospital because we want to make sure that there are no transfusion reactions with the transfusion. It is very rare that we would see a transfusion reaction, but we like to watch you for a couple hours after your cells are infused. And at Northside, we do these procedures outpatient, so if you don't have any reactions to the cells, then you go home that same night. And like I said, once the cells are back into the patient, we consider them a living drug, and that's really when they're gonna do their magic. So now I'll talk about some of the indications for CAR T and how effective these products have been shown to be. This is a busy slide. I'm going to walk through each one just briefly, but right now we have 7 FDA-approved CAR T cell products. And the target antigen is listed there. As you can see, 5 of them target CD19, and that's an antigen or protein expressed on B cells. And B cells are the cancer cells in these diseases. So these are B cell lymphomas, B cell leukemias, and the other 2 products target BCMA, which stands for B cell maturation antigen, which is highly expressed on multiple myeloma cells. And so I just want you to keep that in mind, that we really pay attention to the indications. So the first one is axicabtagene ciloleucel, or axi-cel. It has a lot of approval indications, mostly for B-cell lymphomas in adults with relapsed or refractory disease. Brexucabtagene autoleucel, or Brexi-cel, is approved for B-ALL, which is an acute lymphoblastic leukemia in adults, and also for mantle cell lymphoma. Lisocabtagene marrow-cel, or Lisa-cel, has similar indications to axi-cel, various B-cell lymphomas. Leclusil, or Tisa-cel, is approved for children and young adults up to the age of 25 with B-ALL, and also for different large B-cell lymphomas. Obicaptogene autoleucel, or Obe-cel, is the most recent FDA approval, and this is for B-ALL in adults. And then the two multiple myeloma products we have are Ciltacaptogene autoleucel, or Cilta-cel, which is approved for adults after one or more prior lines of therapy, and then Idacaptogene viclucil, or Ide-cel, approved after two or more prior lines of therapy. So there's a lot of indications for these products, and what I'll mention is that when these were initially approved, a lot of them started off being approved in later lines of therapy, so third or more patients would have to go through at least several lines of therapy, but now we are seeing that they're being very effective in earlier lines of therapy, and they're starting to move up in treatment. So in order to appreciate how important CAR-T has become in our current treatment paradigm and how effective it is, we have to understand what the treatment landscape looked like before it was developed. So prior to CAR T-cell therapy, patients who had relapsed or refractory acute lymphoblastic leukemia, non-Hodgkin lymphoma, chronic lymphocytic leukemia, and multiple myeloma had little chance of achieving a prolonged remission and or a cure. And this is especially true if they failed an allogeneic stem cell transplant or if they weren't eligible for a stem cell transplant. So I'll talk about three buckets of diseases and how CAR-T is really changing the landscape. The first one I'll talk about is B-cell lymphomas, specifically diffuse large B-cell lymphoma, which is the most common in adults. And for diffuse large B-cell lymphoma, we treat it up front with chemotherapy. And in about half of patients, that will be curative. But in the other half of patients, unfortunately, they will experience a relapse after that first chemotherapy. And what we know is that patients who have a relapse within 12 months of initial treatment or who have refractory disease, which basically is that the cancer never goes into remission and it persists after treatment, indicating that it's highly resistant to that treatment, those patients tend to respond poorly to getting additional chemotherapy. And before CAR T-cell therapy, patients who had early relapse or refractory disease had a survival of only several months. With CAR T-cell therapy in non-Hodgkin lymphomas, and diffuse large B-cell lymphoma is a type of non-Hodgkin lymphoma, I kind of lumped it all together for this slide, there is the potential for cure with CAR T-cell in a subset of patients. And we're seeing quite high response rates. So I got this data from over 10 studies that have now more than 2 years of follow-up data. And the overall response rates were between 44 to 91%. Importantly, the complete response rates, meaning that when we look at scans and all of the traditional tests that we do to see if the cancer is still there, the cancer is not there, so that's a complete response. They're quite high, between 40 to 70% reported. And in the patients who had complete responses, the duration of response can be quite long, so on the order of more than 2 years. And at that point, that seems to suggest that those patients might be cured because they're not receiving subsequent treatment. For another bucket of disease, B-cell acute lymphoblastic leukemia, which is an aggressive acute leukemia, before CAR-T, long-term survival was also measured on the order of months. If patients relapsed or had refractory disease, it was estimated that only about 25% would survive to 3 years after their relapse. And it remains difficult to treat refractory disease for sure, but before the use of CAR-T, patients who had refractory disease had very limited options. Even an allogeneic stem cell transplant wouldn't be an optimal option for patients who would continue to have disease persistence after chemotherapy. And in addition, not everyone is a good candidate for a stem cell transplant, and CAR-T offers a potential for disease control in patients who have really difficult to control disease. So for B-ALL, what we're seeing is for patients who are treated with CAR-T, there is the potential for cure. However, we do think that there are still some patients that need a consolidation treatment, meaning that they need some treatment after the CAR T-cell therapy to maintain long-term remission, and most often we consider a stem cell transplant if eligible. But in the trials, the complete response rates, again, were very high for the different CAR T-cell products, exceeding 80% in most studies. And as I mentioned, the duration of response, the patients might need to have subsequent treatment after, because the duration of response tends to be a little bit shorter than what we see with the non-Hodgkin lymphoma patients. When we look at the trials, younger patients tend to have longer remissions and do a little bit better than adults. So when I say younger, I mean pediatrics and young adults. And then multiple myeloma is really an exciting area for CAR T. So relapse refractory multiple myeloma before CAR T, again, had low likelihood of achieving a complete response using traditional treatments. And traditional treatments are generally a combination of chemotherapy drugs and different immunomodulators. So if patients did achieve a complete response or a response prior to CAR T with the traditional therapies, generally the response is expected to be short-lived. And multiple myeloma, as many of you probably understand, tends to have continuous therapy, meaning that patients will be receiving therapy while their disease is still active or being treated. And so it's difficult to have treatment-free remissions, periods of time where patients aren't receiving any treatment in myeloma. But CAR T is an option to help with that. So in multiple myeloma, the efficacy of CAR T has been really exciting. We are seeing prolonged remissions, although at this time it's not believed to be curative. So the complete response rates exceed 80% for one of the products, Cilta-cel, and are very promising for both products. There are prolonged durations of response that we're seeing, so in the order of years. We do notice that the responses tend to wane over time, meaning that we don't think that this is a curative therapy, but it does offer a treatment-free remission period for patients of a couple years after just one cell infusion. So as you can see from all the data I just discussed, CAR T cells are dramatically effective and historically difficult to treat in blood cancers. Okay. So let's talk about some of the common and potential side effects of CAR T and then how we manage them to help patients get through these treatments safely. This is a timeline of potential side effects. Briefly, I'll mention the early days, so days -5 to -1 is a general time frame. This is when patients will be receiving that lymphodepleting chemotherapy, the low-dose chemo, to ready the body to receive the T cells. And with chemotherapy, you can have some nausea, vomiting. We tend to control this very well. And I would say generally in those days leading up to CAR T, patients don't have many side effects. They feel quite well. Day 0 is the day of the cell infusion. On the day of the cell infusion, as I mentioned, the patient comes into the hospital, gets the cells, and then if they're doing well, can go home that same day. Very rare to have side effects with a cell infusion. And I'll spend the next couple of slides really talking about the first 3 weeks after CAR T, which has these unique side effects of CRS, ICANS, and infections, which I'll go into in detail. And then I'll pivot then to beyond those first 3 weeks. So I'm going to talk through some of the side effects with a case of a patient. So this is KJ, and KJ received axicabtagene cilta-leucel for relapsed diffuse large B-cell lymphoma. On day +3, KJ has a fever of 102 degrees Fahrenheit, his blood pressure is 128/75, and his oxygen saturation is 100%. And he's found to be neutropenic with an absolute neutrophil count less than 500. So this presentation of an isolated fever is classic for the most common unique side effect of CAR T cell therapy called cytokine release syndrome, or CRS. So cytokine release syndrome is the most common CAR T specific side effect. It most commonly occurs in the first 14 days, and it can last anywhere between 1 to 10 days. The symptoms are listed here. Fever is always the first sign of CRS. So every patient with CRS will have a fever. Not every patient with a fever will have CRS though. You can also have chills or rigors. If the CRS is persistent or progressive, sometimes blood pressure can drop, heart rate can go up, and then oxygen saturation can go down. CRS is basically a manifestation of the CAR T cells doing their job. So this means that your immune system is active, the CAR T cells are latching on to that target antigen on the cancer cells, and they're leading to this basically supraphysiologic inflammation. And the activation of the immune cells is not only of the T cells, but also of other immune cells in the patient's body, such as macrophages, monocytes, other immune cells that help in this process. And those immune cells release what we call cytokines, which are inflammatory molecules. And the most notable one is IL-6. You don't have to remember this, but I'll bring it up later. It stands for interleukin-6, and it's one of the most important cytokines in this CRS process. So as I mentioned, fever is always the first sign of CRS, but it can affect any organ. And in this day and age, death from CRS is extremely rare because we're able to recognize it early and we have really effective treatments for it. And then lastly with CRS, while fever is often a sign of it, it's also important that we as your providers recognize that it can also be an infection. And so at the same time that we're managing CRS, we also treat for infection by starting antibiotics and making sure that we're checking for infection. So KJ is started on broad spectrum antibiotics to cover the potential for infection while he's febrile and neutropenic. And the next day, on day +4, he spikes another fever to 103 degrees Fahrenheit, and now his blood pressure is a little low at 95/60, and his oxygen saturation remains 100%. So he receives IV fluids and his blood pressure improves, and he started on a medication called tocilizumab. So this gets into how we treat CRS. Most cases of CRS are self-limiting, and early signs of CRS, such as fever, must always be reported to your CAR T cell team. So even though it's potentially self-limiting, if you have a fever after CAR T, it's extremely important that you tell your CAR T cell team, because we will have you come into the hospital so that we can watch you and make sure that we're treating you appropriately. And if CRS persists, like in the case of KJ where he had another fever the next day and his blood pressure was a little low, we treat based on the severity of symptoms. So always we're going to support and give things like IV fluids, antibiotics to prevent or treat infection. In the case of KJ where the fever persisted and the blood pressure was low, we added tocilizumab, which is an IV medication, and it specifically targets that IL-6 that I mentioned, one of the most important cytokines that's elevated in this process, and that reduces inflammatory response. And in severe cases of CRS, we do add steroids. Okay, so KJ's fever resolves and his blood pressure remains stable after 1 dose of tocilizumab. On day +7, so a couple of days later, his nurse finds that he doesn't know the city he's in or the month of the year, and his handwriting is illegible. His ICE score is 7 out of 10. So what is happening now is what we would call ICANS, or immune effector cell associated neurotoxicity syndrome. It's the second unique side effect of CAR T cell therapies in that early period. And so ICANS can occur with CRS, but it is its own entity and it's managed differently than CRS. The symptoms are commonly things like tremor, difficulty writing, word finding difficulty, decreased attention, increased somnolence and confusion, and in very severe cases, seizure. And the process is very similar to CRS in that the cause is excessive immune activation and inflammation, but in this case, the immune cells are able to cross the blood-brain barrier, which is that barrier between the rest of your body and your spinal cord and brain, and so that can cause neurologic symptoms if there's inflammation in that space. ICANS usually occurs after CRS, and that means it's a little bit later, so usually within the first 2 to 3 weeks rather than that first week. And it is often self-limited with CRS, but it can be very severe if it progresses, and so we always want to know if there are signs of developing ICANS, because we will take you into the hospital and make sure that we're managing it appropriately. So what was this ICE score that I mentioned? So the ICE score is a clinical decision tool that we use, and it stands for Immune Effector Cell Associated Encephalopathy. There's a maximum of 10 points, and there are 5 different domains that we test, and they're kind of listed here. I know the figure is small, but I'll go through each one. So one of them is orientation. So we'll ask you, like, do you know what year it is? What month is it? What city are you in? What hospital are you in? You get a point for getting each of those. We ask that you name 3 objects. So point to things in the room, like point to a light or a clock or a button. And if you can name those, then like, okay, good. We ask you to follow simple commands. So for example, can you show me 2 fingers? Can you hold up 2 fingers? Handwriting is assessed. So we have the patient pick a sentence on the first day and then write that same sentence on subsequent days, and we can see the change in handwriting. So if you can see this, the sentence starts off pretty legible. I have 3 dogs, 3 cars, 3 motorbikes, and a jet ski. And then by the end, it's really like nonsensical. And the last domain that we test is attention. So we ask patients to count backwards from 100 by 10. And this ICE score is assessed daily. If there are signs of ICANS, then we increase the frequency. Treatment for ICANS, like I said, is different than treatment for CRS. Always we provide supportive care. For our CAR T patients, we start them on a prophylactic anti-seizure medication throughout this process. And if there are signs of ICANS, sometimes we'll get things like an EEG to look for seizure activity, imaging of the brain. We'll make sure that there are precautions, for example, so that you don't eat or drink lying down, that your head is elevated when you're eating or drinking. If ICANS is severe or progressing, we start steroids, and we start that early. That seems to be very effective in ICANS. There's not a good response of tocilizumab, so we don't use tocilizumab. It can actually worsen ICANS sometimes, so we avoid that, but we use it for CRS. And then in more advanced cases, we do have an IV medication called anakinra, which targets another cytokine called IL-1, and this has been beneficial in cases of ICANS if needed. Okay, so those were the 2 very unique side effects of CAR T-cell therapy. Infections can happen after CAR T. I'm sure you're all familiar with infections and the concept of them, but basically if your immune system is compromised, you're at higher risk for infections, and so the highest incidence of infections after CAR T is within the first 30 days, and that's because of that low-dose chemotherapy that we give. It can drop your blood counts expectedly for a couple of weeks. Within those first 30 days, we do expect that bacterial infections would be more common, and then after 30 days, viral infections are more common, but you can have both at either time point, of course. And fungal infections are quite rare with CAR T-cell therapy. We do recognize that there are a lot of risk factors for infections for patients undergoing CAR T. Some of them include the use of steroids. So if you have ICANS or CRS and we treat it with steroids, that can decrease the function of your immune system. If patients come into CAR T having received a lot of prior therapy, then their immune system might not be as robust going through. So we always keep those things in mind. Okay, and after those first 3 weeks, the side effects are quite different. So within the first 3 weeks, I mentioned CRS and ICANS can happen. After 3 weeks, it would be quite rare to see CRS and ICANS, but we can see other side effects that we manage differently. Some of the possible long-term effects of CAR T, I'll talk about 3 of them, and these don't happen to every patient. I want to emphasize that, but I want to make you aware of some things. prolonged low blood counts. So we call low blood counts cytopenias, and we know, as I mentioned, that low blood counts are commonly seen with CAR T, and that's because of that chemotherapy that we give. But we expect that these low blood counts would be short-lived, and that after a couple of weeks, blood counts will return to normal or almost normal. But in some cases, some patients can have persistent low blood counts, and when I say blood counts, I'm talking mostly about neutrophils, which are a type of immune cell to help fight infection, and platelets, which help to clot and prevent bleeding. If blood counts remain low, this can lead to, of course, increased risk for infections, need for blood transfusions, and sometimes we have to add medications or additional treatments to help boost the cells to come back in. B-cell aplasia leading to hypogammaglobulinemia. So this, I'll talk you through all of those words. So I mentioned that the FDA-approved products all target an antigen on B cells. So they're approved for B-cell lymphomas, B-cell acute lymphoblastic leukemia, multiple myeloma, which is a disease of mature B cells. And so what B-cell aplasia means is that all the B cells are gone. And that's actually a sign that the CAR T cells are working. We want to see that B cells are gone because that predicts that the CAR T cells are persisting and doing their job. But B cells also have a job, and that's to produce antibodies or immunoglobulins to help fight infection. And so with the elimination of the B cells, which is what we want, we also get elimination of some of your long-term immunity, so your immunoglobulins. And the way that we can help prevent infections is by giving back immunoglobulins through an IV infusion, and we call it IVIG. And then the last long-term side effect potentially that could happen that I want to make you aware of is something called delayed neurotoxicity. And delayed neurotoxicities following CAR T are rare, and they're much less well understood than the other two side effects I just mentioned. These toxicities can sometimes manifest as symptoms of Parkinson's disease, cranial nerve palsies, or peripheral neuropathies. And if we see these start to develop, we generally treat with steroids. Okay, so there are a few logistical considerations that I want to make you aware of in case you or someone you know are considering receiving these therapies. 24/7 caregiver, that is extremely important, and you can understand the importance of that because of some of the side effects that I talked about. So if it's the middle of the night and you have a fever, you need someone to help you call in and get to the hospital at that time. Same thing if you're starting to get confused or having trouble finding words or things like that. So we do ask, or we request and require that a 24/7 caregiver be available for the first 4 weeks and sometimes longer, depending on how you're doing. We require that patients live within 1 hour of the hospital, and that is because if a side effect occurs, we want to be able to get you to the treatment center quickly so that we can manage it. If you don't live within an hour of the hospital, we have many ways to help with local lodging. There's hotels and lodging that we can put you up in for the period of time for those first 3 to 4 weeks while you're receiving CAR T and those side effects are the most pressing. Daily clinic visits through day 21. That's specific for Northside because we do our transplants outpatient or our CAR T outpatient. And so after that day 0 infusion, you go home, and then we ask that you come back to the clinic every day for the first 21 days. And then after that, we assess how frequently you need to come back. And then no driving until day 60, and that's because of the risk for seizure and disorientation, forgetting where you are, so really just to keep you safe and other people safe on the road. Each patient also receives a wallet card that's specific for the CAR T cell product that they received, and this wallet card should be taken with you in case of an emergency, and it lets the responders and healthcare providers know that you received a CAR T cell product and what to do. And then self-care is often overlooked, but we emphasize it quite a bit because these things will help you get through CAR T safely and to be strong at the end. So exercise, I'm not talking about running every day or lifting weights, but I'm talking about just being mobile, walking around your house, and staying active. So doing everything at home and through the CAR-T treatment that you would do if you weren't receiving it. Mouth care is something that we really stress in the first week or two because your immune system is weakened. Bacteria and other organisms can go from your mouth into your bloodstream because the mouth is an area that's quite dirty. And so we give you mouthwashes and special toothbrushes and really help you to keep the mouth clean so that you don't get an infection that way. Nutrition, I don't have too much to say about this, just that we like to make sure that you're still eating and drinking, and if you can't eat because you feel nauseous or other things, then at least drinking, and we really encourage those protein shakes like Ensure, Boost, Core Power. And even if you can't get to that, then we have other ways to help you with nutrition, and we have nutritionists as well. But we're always going to make sure that you're getting the intake that you need so that your body can go through this process. And then avoiding sick contacts. We, of course, want you to avoid people who are coughing, have a cold, and to avoid crowded places for those first 3 to 4 weeks at least. So no grocery shopping, no going to the movies, things like that, just to keep yourself safe. All right, so we're rounding the corner. Future directions for CAR-T. There's a lot of exciting things on the horizon for CAR-T. These are just a few of them, and I'll talk briefly about them. New targets and diseases. This is really important because, as I mentioned, all of the products approved are for B-cell diseases and multiple myeloma. But of course, we all know that there are diseases such as T-cell leukemias, lymphomas. There are solid cancers such as lung cancer. And there are autoimmune diseases that aren't cancers but people have, such as lupus and other things. And so these are all active areas of research right now for CAR T-cell therapy, looking at ways that we can use these in different diseases. Dual antigen targeting is such an interesting concept. So that means that instead of having one receptor put on the T-cell, we can put two. And sometimes they're even studying 3 now. And that would be helpful because, like I said, cancer cells are very smart and sometimes they can find ways to get around that one receptor. And if there are 2 different receptors that are targeting 2 different antigens, then it really decreases the chance that the cancer can outsmart the immune system that way. Expedited manufacturing time is something that we're always thinking about. Because from the time of T-cell collection to infusion, as I mentioned, it's at least 4 weeks and sometimes longer. And so a lot can happen in those 4 weeks where maybe the cancer progresses or something happens that the patient is no longer able to receive the CAR T-cells. And so if we can shorten the time to manufacture, then that would allow more people to receive these therapies. Interventions to reduce toxicity, there are so many. One of them, for example, is looking at infusing chemotherapy or anti-inflammatory drugs into the cerebral spinal fluid, so the fluid around the brain and spinal cord, to help prevent some of that neurotoxicity. And then allogeneic CAR-T is in clinical trials right now. Very, very exciting concept where instead of using the patient's own T-cells, we call that autologous, meaning that it comes from yourself. We use T-cells from healthy donors, or allogeneic, meaning it comes from someone else. And so the healthy donors without the cancer donate their T-cells, and those T-cells undergo a similar process where they're sent to a lab, they're manufactured, and then they're infused into the patient. And as you can imagine, this would cut down on the time to manufacture. We consider it essentially a quote-unquote off-the-shelf therapy because if we have a patient who needs CAR T-cell therapy, we can get them the cells much quicker because they don't have to go through that collection process. And my last slide is on the importance of clinical trials. Advancements in science are a collaborative effort, and we really have the patients to thank for enrolling in clinical trials and helping us to understand how these therapies work. So here are some really nice concepts and importance of clinical trials. So development of new therapies. Clinical trials really help us assess the safety and efficacy of new products. They can help us find ways to improve quality of life for patients, and then of course to identify any adverse effects so that we can prevent them or treat them appropriately. Clinical trials have the potential to change medical practice, and CAR-T is a prime example of that, where now treatment of these lymphomas, leukemias, and myeloma are completely different than they were 5 to 10 years ago. Access to cutting-edge treatments is something that may not be applicable to every person or something that interests you, but for patients who have gone through many, many lines of treatment and there are not many good options left commercially, being enrolled in a clinical trial can allow you sometimes to access a new therapy before it's gone through the full approval process. And the benefit to future patients is really an altruistic concept where if you're put on a clinical trial and you don't receive the therapy, or you receive it and it doesn't help, that knowledge is not lost, and that knowledge will benefit patients in the future because of what we learned about patients on the current trial. So in summary, CAR-T cell therapy is clearly an important treatment option for many patients with relapsed B-cell leukemia, lymphoma, multiple myeloma, and many patients are now achieving complete responses and durable remissions. And there's likely a subset of patients, for example, with lymphoma, who are even cured of their disease after CAR-T cell therapy. We're becoming much better at prevention and early recognition of toxicities of CAR-T cell therapy so that more people can safely receive these treatments. And there are many new exciting approaches to CAR-T on the horizon, and it's thanks to patients, family, and supporters like you that help us make these possible. So, thank you.
So I'd like to transition to the question and answer portion of the presentation. If anyone has any questions for Dr. Desai, I'd like to open the floor.
You didn't mention CLL specifically, and I know that it has been used, but maybe not with the same kind of good results. Has that improved at all, CAR-T cell therapies for CLL?
I would say that the results that we're seeing are very similar to in the initial trials, but CLL has so many more therapies besides CAR-T, and I think the bigger question is how to sequence the CAR-T with CLL. A lot of the promising results that we're seeing with CAR-T is that it's being used earlier and earlier in treatment. So myeloma is an example. Instead of after 4 lines of treatment, it's now after 1 or 2. And so potentially if we start to see the use of CAR-T earlier in CLL, it might have more promising results because patients who have received a lot of treatment before they go to CAR-T, their T cells might not function the way that they would have a couple lines of therapy before. They might not be as robust. There are other factors that can really affect the activation and the propagation of the T cells that we don't really understand yet. But hopefully we start to see CLL have a little bit more of a benefit with the CAR-T. Yes, in the back.
Yes. Is there, or what's the current data on how long CAR-T is effective?
Yeah, good question. It does vary based on the product and the disease. And so, do you have a specific disease that you're thinking about? Large B-cell lymphomas. Right. So that is one of the biggest indications for CAR-T right now. So what we're seeing with large B-cell lymphoma, and it's now, as I mentioned, one of the indications for use after 1 line of therapy if the disease comes back early or it's refractory. In about half of patients, they will stop responding to the CAR-T at some point. But in the patients who achieve a complete response, that remission can be several years, and we do think that at that point we're continuing to follow because the data is not quite mature yet, but we do think that some patients are cured of their disease for large B-cell lymphoma.
Like we were told we were going to be followed for like 15 years. that still like the standard?
I would say that we always follow for as long as we can. So if we can follow you for 15 years, we will. If we can follow you for 50 years, we will. So there is no limit. But generally after 2 to 5 years, we consider that it's safe. Yes.
You mentioned that after CAR-T that the T cells can self-propitiate. How long will they continue to do that?
Depreciate?
Yeah, I think you said that they, they'll continue to, self.
Oh, to propagate. Okay.
Yeah, propagate.
Yeah, that's a really good question, and one that there's mixed, or not mixed data, but it varies patient by patient. And some patients we see loss of the CAR T cells early, and we don't know why. In some patients, the T cells are still there. We can measure it in blood and in the brain fluid, the CSF, and they're there for years. So we don't yet know which patients will have that prolonged persistence of the CAR T cells, but it can be very, very long.
Question, is there, with CAR T, is there maintenance after you shoot the CAR T, like if you have a stem cell, then you revenue some?
Yeah, good question. So in multiple myeloma after stem cell transplant, like you mentioned, we do maintenance, which is usually with 1 or 2 drugs. In CAR T cell, we don't. So it's 1 infusion, and that's because the T cells, the CAR T cells, are the living drug, and if they're still around, they should still be that maintenance therapy for you.
Yes, it has been discussed nationally and internationally that we might be on the cutting edge soon, but no doctors want to commit to that the CAR T cell is going to replace the stem cell transplant. Any idea on when that measure may come in the future? And my last question is, for stem cell modification in the southeast where we are located, what is the location of the manufacturer that's doing those stem cells in what state?
Good questions. So for your first question, we do not believe, and I work at a transplant program as well as the cellular therapy program, that CAR T cells can replace transplant at this time. And a couple reasons for that, but one of them is that we just don't have the long-term data yet to say, because some of these products were only approved a year, 5 years ago, and so we don't know if they're curative. Stem cell transplant is a potentially curative therapy. It's also somewhat of a living therapy, and so we have different indications for transplant as for CAR T, but we would not say that CAR T is replacing stem cell transplant at this time. They can be used together at some time, so we can sequence them. Some patients may receive CAR T cell therapy and then go on to receive a transplant to achieve that really long remission and potential cure. And so that's a really beneficial way that we use both of them together now. And then the second question, I don't know the locations of all of the different manufacturing companies, but it depends on the product. So there are several different pharmaceutical companies that manufacture these, and we ship them all over the country.
There's a bispecific T cell engager, TCE, that binds to the BCMA. I was on that for 6 months. It's working great. Now, does the T cells get worn out over time, or how do they keep the T cells engaged?
You are asking such good questions that many researchers are asking too.
It's working great.
I'm so glad that it's working for you. So the concept you're referring to, we call T cell exhaustion, and T cells, if they work and they're doing that job of killing cancer cells and activating the immune system for a long time, they can get tired, and we do see that. For products that target BCMA, like the product you're on, we do have some understanding that that target antigen can, if we use CAR T that targets BCMA after, we might not have as robust of a response because your T cells have already been recognizing that antigen through that product that you're getting. And so we do have to be mindful of therapies before giving CAR T if they target the same protein.
So, okay, so you can, if it's fatigue or it goes away, they can get another dose of it, so it can.
Oh, you're asking if we give another dose of CAR T cells?
Right.
Not at this time, no.
So it's only one time dose, and that's it. So if you're giving your T cells fatigue and go away, you have to go to another.
Right. If you receive CAR T cells and maybe you have a response and then you have a relapse, unfortunately, and we think it's because the T cells went away, we wouldn't use the same product. If there's another CAR T cell product that targets a different antigen, then maybe we could consider, but at this point, we don't really have that.
You talked about increased efficiency or speed of manufacturing. Are there processes in place to make sure that the same level of, I guess, quality, exactly, of the manufacturing is in place? How is the manufacturing monitored?
Everything is monitored through the FDA. I don't know, quite honestly, the specifics of each company and all of the regulations they have in process or in place, but I know that there are many, many safety checks, and I can't really answer more details than that, to be fair.
Okay.
Additional questions? So you